Today, I'm going to talk about gallstone disease. It's a very hot topic in any general surgery residency. It's the bread and butter of general surgery, gallstone disease. Everybody should know about gallstone disease wherever they go into whichever specialty of or subspecialty of surgery, they still need to know about gallstone disease. Medical students, surgical trainees, primary healthcare physicians, it's a very common and relevant disease. So I will focus on it and on its complications. The prevalence is high. So in autopsy reports, it's estimated to be between 11 and 36% of patients, or in autopsies, they will find gallstone disease. The risk factor for gallstone disease are female sex, obesity, pregnancy, fatty food, weight loss, Crohn's disease, terminal ileal resection, sickle cell disease, and hereditary spherocytosis, as well as thalassemia. All of these will increase the risk of the formation of gallstone disease. It essentially represents an inability to maintain certain biliary solutes, especially, so especially, one second, I'm just going to need to move this down. Especially the cholesterol and calcium salts. And gallstones are classified by the cholesterol content as either cholesterol or pigment stones. And pigment stones in itself are further classified into brown or black pigment stones. In the developed world, most of the gallstones are cholesterol gallstones. They constitute about 70 to 80% of all gallstones. Sometimes you will get an ultrasound for a patient, and they will tell you that there is a biliary sludge. What is a biliary sludge? It's not a stone. It's basically a mixture of cholesterol crystals, as well as calcium bilirubinate granules, and the mucin gel matrix. But it can cause the same problem and the same complications as gallstones. So how do gallstones present? Before I go into the complications of gallstones, we need to know something. Not everybody with a gallstone needs the gallbladder out. You only take the gallbladder out if the gallbladder is causing complications, which are the following. In the next few slides, I will talk about the complications of gallstones. But it's essential to note that not everybody with gallstone will need a cholecystectomy, because 98% of patients with gallstones in their ultrasound will continue their life without symptoms. We only need to take the gallbladder if symptoms do start, and if the gallstones are causing complications. This is a very important message. The most common complication of gallstone disease is chronic calculous cholecystitis. Basically, there will be an ongoing inflammation with recurrent episodes of biliary colic due to pain from the cystic duct obstruction. This is referred to chronic cholecystitis. So biliary colic is the classic constellation of symptoms, or the pain associated with chronic cholecystitis. 2/3 of patients with gallstone disease will present with repeated attacks of biliary colic, and it's the most common complication of gallstone disease. So the clinical presentation will be pain, referred often to biliary colic. The pain is constant. It usually lasts from 1 to 5 hours. The attacks will last more than 1 hour, but usually they will subside by 24 hours. There will be an accompanying symptom of nausea and vomiting, along with the pain. The pain and the symptoms will be precipitated by eating a fatty meal. This is important. So biliary colic will be precipitated by having a fatty meal. There will be pain in the right upper quadrant, sometimes radiating to the back, associated with nausea and vomiting. The differential diagnosis should include peptic ulcer disease, pneumonia, renal calculi, rarely liver disease, or angina. But most commonly, you need to differentiate it from acute cholecystitis, peptic ulcer disease as the two commonest differential diagnoses in that area. The second problem is cholecystitis, which sometimes can come with emphysematous cholecystitis. In this picture of the CT scan, there is emphysema, there is air in the gallbladder wall. This is called an emphysematous cholecystitis. In terms of cholecystitis, what is the difference between cholecystitis and biliary colic? In cholecystitis, you will have severe and longer duration of pain. On examination, you will find guarding. You will rarely find guarding with biliary colic or chronic cholecystitis, but you will find guarding and tenderness in acute cholecystitis. Merisi sign will be positive, in which there will be a cessation of breathing when the patient is taking a deep breath in, when your hand is in the right upper quadrant. Also in the lab tests, you will find leukocytosis and sometimes a slight elevation of the transaminases and amylase. If there is severe jaundice along with acute cholecystitis, could be due to common bile duct stones or obstruction of the bile duct by pericholecystic inflammation, or due to a stone in the neck causing a compression, and it's called Merisi Syndrome. We'll talk about that later. How do you diagnose acute cholecystitis and differentiate it with biliary colic? You need to do an ultrasound. It's the most useful radiographic test for diagnosing acute cholecystitis. The sensitivity and the specificity of the ultrasound is high. It will identify the gallstones. It will also shows thickening of the gallbladder wall. With the chronic cholecystitis, you will not most likely find thickening. There will be a pericholecystic fluid and gallbladder distension. And there will be also a sonographic Merisi. The patient will stop breathing when when the ultrasound probe is pressed on the gallbladder, when the doctor asks the patient to take a deep breath in. Another test that can exclude acute cholecystitis is the HIDA scan. If you don't get filling of the gallbladder with the HIDA scan after 4 hours, this will indicate an obstructed cystic duct, and it will have a very high sensitivity and specificity for acute cholecystitis. So why do we need to know whether the patient is having a biliary colic or acute cholecystitis? Because with biliary colic, you can schedule the patient for an elective cholecystectomy. But with an acute cholecystitis, it's better to do the operation within 1 week of the presentation. There is a controversy in that topic, which we will be coming to discuss in the next few slides. So in general, what are the indications for cholecystectomy? Acute cholecystitis, emphysematous cholecystitis, empyema of the gallbladder in which there is pus in the gallbladder, perforation of the gallbladder, which is rare, usually following an empyema or following an emphysematous cholecystitis. If there is an obstruction of the common bile duct requiring an endoscopic duct clearance. These in general are urgent indications of cholecystectomy, as well as gallstone pancreatitis. Elective indications will include biliary dyskinesia and chronic cholecystitis. Now, this is the controversy about the timing of cholecystectomy in acute cholecystitis. There's a nice Cochrane review published in 2013. They identified, Cochrane reviews are a collection of meta-analysis. So it's essentially a meta-analysis. They identified 7 trials and included 6, which had 488 patients. They defined early lab chole as duration of symptoms of less than 7 days versus a delayed cholecystectomy, which is which they define as performance of the cholecystectomy after 6 weeks of presentation. So the classic teaching was that if you have a patient presenting with cholecystitis, you need to do the cholecystectomy within 3 days. If you miss the 3 days window, you need to wait for 6 weeks. But with this study, it showed actually that there is, now coming back, let's go back. Why do we like to do an early cholecystectomy as opposed to a delayed cholecystectomy? The issue is bile duct injury. Bile duct injury is the most feared complication of a cholecystectomy. And when in the early 90s, late 80s, when surgeons starting to shift from an open cholecystectomy to a laparoscopic cholecystectomy, there was an increase in the incidence of bile duct injury. So there was a consensus that you need to do the cholecystectomy early in acute cholecystitis to avoid bile duct injury, because after 3 days, you will have fibrosis in the area and it will be harder to identify the proper structures and avoid the bile duct injury. But in this study, in this Cochrane review, we know that there was no difference in bile duct injury between the early cholecystectomy and the delayed cholecystectomy. And the early cholecystectomy here is not within 3 days of presentation of symptoms, it's within 7 days of presentation of symptoms. So they push the boundary a little, if you like to say. And there was no difference in the proportion of people who required an open cholecystectomy between the two groups. The hospital stay was actually shorter in the early group when you compare it to the delayed group. And there was no difference in the timing between the two groups or in terms of the serious complications. So you can actually still go ahead and do your cholecystectomy within 7 days of the presentation of acute cholecystitis. The next topic, the next complication of Gallstone disease is Gallstone pancreatitis. We all know that's the second most commonest cause of pancreatitis are gallstones. The first cause is alcohol, of course. So how would you manage a patient with Gallstone pancreatitis? You manage them the same way you manage any pancreatitis. Patients should be MPO, you hydrate them, you can give them imipenem if the pancreatitis is severe, and you should start enteral feeding. Once the pain disappears, so even if the amylase is high, even if the lipase is high, if the pain on examination disappears, if the patient is not complaining of pain, you should go ahead and perform your cholecystectomy. It's called the same admission cholecystectomy. And it's effective in 97% of cases in preventing recurrent episodes of Gallstone pancreatitis. Because if you let the patient go home after an attack of Gallstone pancreatitis, there is a high chance of readmission with pancreatitis. Approximately 50% of patients with Gallstone pancreatitis will present again within 6 to 12 weeks after discharge. So you like to do the cholecystectomy at the same admission in these patients. Now, do you need to do ERCP? That's an important topic and a controversial topic in Gallstone pancreatitis. Why did the patients develop the Gallstone pancreatitis? Because stones did obstruct probably the common bile duct and affected the pancreatic duct. But we know that most of the stones that cause Gallstone pancreatitis pass on their own. So we don't need to perform an ERCP in Gallstone pancreatitis unless the bilirubin is high. Let's say the bilirubin above 80. Then we might perform a clearance of the bile duct before the cholecystectomy. I prefer to do an MRCP first if the bilirubin is high. If the bilirubin is not high, I would not perform even an MRCP, and I will go ahead and do a cholecystectomy. But if the bilirubin is high, I will do an MRCP first before clearing the duct prior to a same admission cholecystectomy. Now, When do you do ERCP? You can do it in severe gallstone pancreatitis, if the patient is having also a very high bilirubin. You should delay the cholecystectomy for about 3 to 4 weeks if the patient presented with severe pancreatitis, because you want to make sure that there are no complications associated with the cholecystitis when you perform, associated with the pancreatitis when you perform your cholecystectomy. What do you do if the patient is pregnant? And that stands in pancreatitis and even in cholecystitis. Cholecystectomy is relatively safe in the second trimester, but not in the first trimester. So you try to delay your cholecystectomy if the patient is in the first trimester and do it in the second trimester. In the third trimester, some surgeons will still go ahead and do it, and some will prefer a more conservative approach until the patient is delivered. But the best time, until the baby is delivered, but the best time for the cholecystectomy in pregnancy is in the second trimester. What about biliary dyskinesia? Now, biliary dyskinesia, I shouldn't put it there. It should be at the end of gallstone disease, because it's not caused usually by gallstone disease. In biliary dyskinesia, you can do an ultrasound and find no gallstones, but the patient will complain of the same symptoms as biliary colic. They will describe pain in the right upper quadrant after eating a fatty meal. The ultrasound will be negative. How do you diagnose this? You'll do a CCK HIDA scan. The CCK is infused intravenously after the gallbladder is filled with technetium-labeled radionuclide. After 20 minutes of administering the CCK, the gallbladder ejection fraction will be determined. If the ejection fraction of the gallbladder is less than 35% at 20 minutes, this is considered abnormal, and this is called the biliary dyskinesia. How do you consult the patient? You should tell these patients that there is a 50% chance of the symptoms disappearing after the cholecystectomy, but it's not a guarantee that the symptoms will disappear after a cholecystectomy in biliary dyskinesia. Now, let's go back to gallstone disease complications. Merisi Syndrome. In Merisi Syndrome, basically there is a large stone in the neck of the gallbladder that is putting pressure and obstructing the common bile duct. And basically, essentially, it's of two types. Merisi type 1, the stone is just putting pressure on the common bile duct. But in Merisi type 2, there is a fistula formation between the gallbladder and the common bile duct itself. And this will have challenges during the cholecystectomy. In the past, we used to say that if you know that the patient is having a Merisi syndrome, you should do an open cholecystectomy. But now it is acceptable to do a lap chole in Merisi syndrome. You should consult a hepatobiliary surgeon, especially if the patient is having a Merisi type 2, because you might need to do a reconstruction of the common bile duct after resecting the gallbladder. Now, this is an ERCP of Merisi type 1. You can see there is a smooth, long stricture. It's smooth, long, and regular stricture. This is caused by a pressure from a large stone in the gallbladder neck. But here you have a type 2 Merisi, whereby there is actually a filling defect of the common bile duct itself. This is another ERCP in Merisi type 2, in which there is a fistula between the gallbladder and the common bile duct. The whole gallbladder seems to be, or the whole stone seems to be fistulizing into the common bile duct. Cholangitis, it's a medical emergency. It's caused by cholecystitisis, in which there is a stone in the common bile duct. You need to hydrate the patient, broad spectrum IV antibiotics, and decompress the patient by performing an ERCP. There is a charcoal triad in which there is the triad of jaundice, fever, and right upper quadrant pain. It indicates cholangitis. Raynaud's pentad is the addition of altered mental status and low blood pressure, which indicates septic shock. It can be deadly. It's a medical emergency. You need to hydrate the patient, broad spectrum antibiotics, and decompress the common bile duct. And after that, you can perform a cholecystectomy. Elective cholecystectomy is acceptable. Gallstone ileus. It's similar to the Merisi Syndrome, but here the gallbladder is not fistulizing to the common bile duct. It's actually fistulizing to the bowel, and it's usually caused by a very large stone. The gallstone, the very large stone, will migrate from the gallbladder all the way to the and obstruct the narrowest part of the GI tract, which is the terminal ileum. 1% of all causes of small bowel obstruction will be due to gallstone ileus. It's a rare cause for small bowel obstruction. You need to hydrate the patient, take the patient to the operating room, and remove the stone. You should make your enterotomy proximal to the stone in a healthy bowel. Usually the patients will have electrolyte disturbances. Usually the patients will be elderly. You need to hydrate them well, resuscitate them before taking them to the operating room. You do not need to perform a cholecystectomy. You do not need to take the fistula down. You just need to take the stone out, and you don't need to do anything further. Now, let's talk about the operation, the only operation of choice to treat cholecystectomy. We don't dissolve the stones. We don't give medications. We treat gallstone complications with a cholecystectomy, removal of the gallbladder. One of the biggest advances in surgery is the advent of the laparoscope, which made this operation much easier on the patient. In the past, we used to do an open cholecystectomy with a large subcostal incision, but nowadays we perform a laparoscopic cholecystectomy, usually with 4 ports. These are the ports that we insert in the, I'm going to use the laser pointer here. So these are the ports that we use for a cholecystectomy. You can get into the abdomen with an open technique and then insert your ports. I usually put a 10 millimeter port in the epigastric region, 5 millimeter port in the medial side, and another 5 in the lateral side. I use a 30 degrees camera, not a 0 degree camera. And the most important maneuver is to retract the gallbladder towards the tip of the right shoulder using the lateral port. You need to position the patient correctly, head up, right side up, and the surgeon will stand on the left-hand side of the patient. The assistant will be below the surgeon down there. It's important to identify the critical view of safety. We'll talk about that in the next few slides. There is the SAGE's strategy to minimize bile duct injury. Again, the most feared complication of a cholecystectomy is bile duct injury. The incidence is 1 in 2 to 300. It's rare, but it's a devastating complications. It can lead even to a liver transplant if the reconstruction is not performed in an adequate fashion. So these are the 6 points in the SAGE's strategy to minimize the bile duct injury. The most important point is to use the critical view of safety. And there are 3 criteria that SAGE's put in order to achieve the critical view of safety. First of all, the hepatocystic triangle should be cleared completely of fat and fibrous tissue, right? The hepatocystic triangle is defined as a triangle formed by the cystic duct, the common hepatic duct, and the inferior edge of the liver. The common bile duct and the common hepatic duct should not be seen. They should not be exposed. The lower 1/3 of the gallbladder should be separated, as you can see here in this beautiful intraoperative picture from the SAGE's website. The lower 1/3 of the gallbladder should be separated from the liver to expose the cystic plate. The cystic plate is also known as the liver bed of the gallbladder and lies in the gallbladder fossa. Two and only two structures should be seen entering the gallbladder after you do that. And these structures are the cystic duct and the cystic artery. And you should rotate. This is the anterior view of the critical view showing the cystic duct and cystic artery. And this is from behind, the posterior view. This is a nice critical view. Here you can see that the lower 1/3 of the gallbladder is separated from the liver nicely. So it's important to maintain that critical view before clipping the cystic duct and cystic artery. The second point is you need to understand the potential for aberrant anatomy in all cases. Aberrant anatomy of the gallbladder is common. Some of the aberrant anatomy will include a short cystic duct, an aberrant hepatic duct, or a right hepatic artery that crosses anterior to the common bile duct. These are some, but not all the common variants of anatomy of the biliary tree. The third point, or the third strategy, is to make liberal use of cholangiography or other methods if you are not sure about the anatomy. The fourth point is that you should consider an intraoperative timeout during lab chole prior to clipping, cutting, or transecting any ductal structures. The most important point in the intraoperative timeout is to make sure that you are, and everybody in the operating room should agree that you actually do have the critical view of safety. The fifth point is that you should recognize when you are dissecting that there is a problem, that you are approaching a zone of significant risk, and you should halt the dissection before entering that zone. If you feel that you are approaching a risky area in the operation, you should stop and do a safe method other than a cholecystectomy. What is a safe method other than the cholecystectomy? You should do a subtotal. You can do a subtotal cholecystectomy, or you can even put a drain in the gallbladder and get out, and another drain around the gallbladder. But don't persist when you cannot obtain the critical view of safety. Of course, before you do that, you should go to the sixth point there, which is you should get help from another surgeon prior to resorting to a subtotal cholecystectomy. When do you know that you are approaching a significant risky area? When you cannot obtain the critical view of safety. All right. Now, what is this? These are the classifications of the bile duct injury. A lab cholecystectomy is an easy operation. Every general surgery resident should be expected to do this operation, especially by the end of the training, sometimes even earlier. But sometimes this simple operation can turn into a very major operation. So you should always respect a lab chole. You should always treat a lab chole as a major operation. And you should always be humble when you are performing a laparoscopic cholecystectomy, because you don't want to get a bile duct injury. This is the Strasberg classification of the bile duct injury that you should be aware of. In type, there are 4 to 5 types of the bile duct injury according to Strasberg. Type A, B, C, D, and type E, which he classifies further into 4 types or 5 types. In type A, there is bile leak from the cystic duct stump or from the gallbladder bed. In type B, there is an occluded right posterior sectoral duct. It's occluded in type B. But in type C, that duct is leaking. The right posterior sectoral duct in type C is leaking. In type D, there is a side injury or there is bile leak from the main bile duct without major tissue loss. And in type E, there is a complete transection of the common bile duct. And it's further classified according to the distance from the bifurcation. In the worst scenario, there will be a separation of the right and the left hepatic ducts. This is the classic injury that you get in a cholecystectomy. It's a type E injury in which there is a complete transection of the common bile duct. And usually it's because when you do the retraction, you remember when I told you that in the lateral port, you should retract the fundus of the gallbladder to the tip of the right shoulder. If you don't do that, and if the gallbladder is aligned with the common bile duct, you will think that the common bile duct is a cystic duct. And you will do this classic bile duct injury. Sometimes you can go very high, in which you separate the right hepatic duct from the left hepatic duct, which is very morbid. Why is it morbid? Because usually, actually, in 90% of cases in which there is a bile duct injury, there will be a vascular injury, and the vascular injury will usually involve the right hepatic duct, the right hepatic artery. So this is the classic injury with the second, I think there is this is a classic injury in which there is a complete transection of the common bile duct as well as an injury to the right hepatic artery. In some cases, there will be even injury to the portal vein. Now, if you injure the right hepatic artery, there are collaterals with the left hepatic artery that can supply the remainder of the common bile duct. But if you do a complete transection of the hilar plate and you separate the right from the left hepatic ducts, then the reconstruction might not heal very well because of the lack of blood supply. How would you manage a bile duct injury? If you identify it at the time of the cholecystectomy, you call a hepatobiliary surgeon, and they can do an intraoperative repair in the form of a hepatocyginostomy. If you don't recognize it and the patient presents later, then you should wait for about 4 to 6 weeks until you perform the reconstruction. But I have done a reconstruction earlier than 4 to 6 weeks if the patient is stable without significant inflammation in the area. Thank you. That's all for, that's a summary of all the complications of Gallstone disease, the controversies in the topic, and how to avoid bile duct injury during cholecystectomy. Thank you.
Thank you very much, Dr. We do have a few questions in the Q&A panel and the chat box. So we'll first answer the ones in the Q&A channel. One of the first questions they asked were, what are the triggers of gallbladder pain?
Eating a fatty meal.
Okay. And someone else says, what do you do if a patient is not fit for surgery? So what are the recommendations?
So, I mean, fit for surgery is a very it's not a very clear wording. Maybe a patient is fit for an anesthetist and a surgeon and not fit for another. But if the patient is really sick and cannot undergo a cholecystectomy, first of all, we need to know what's the indication of their cholecystectomy. Is it biliary colic? Is it gallstone pancreatitis? Is it acute cholecystitis? The management will be different according to the indication for the cholecystectomy. If it's an acute cholecystitis, you can do a cholecystostomy tube. If it's a biliary colic, you should ask the patient to avoid the triggers causing the biliary colic. If it's a gallstone pancreatitis, some surgeons think that if you perform an ERCP with a sphincterotomy, that can help in avoiding pancreatitis in the future. but it's not supported by evidence. So really, it depends on the patient. If it's a cholecystitis, you can do a cholecystostomy tube, and you can manage the patient conservatively with antibiotics if the patient is presenting with recurrent cholecystitis. But again, we should be aware that probably exposing a very sick patient to recurrent cholecystitis will have a worse outcome than going ahead and performing the cholecystectomy.
Okay. Okay. Someone else asked, what is your approach for gallbladder stones and bile duct stones?
So if you have gallbladder stones, I mean, I guess that he's saying that the patient is having cholecystitis or just gallbladder stones.
Gallbladder stones.
If you have gallbladder stones, that's irrelevant. The problem is that the patient's having bile duct stones. You need to decompress the bile duct and then do a cholecystectomy.
Mm-hmm.
All right.
Okay. Someone else is asking about the superior border of the callow triangle. Is it the cystic artery or the inferior border of the liver?
I mean, these are academic questions. What's important is you need to know the SAGE's 6 strategies for avoiding bile duct injury. And the most important, it's very nicely, you will find different definitions for the critical view of safety. But I think the best definition is the definition of the SAGE's and how to obtain it.
Okay. So someone is also asking, what is the risk of recurrence of gallstone ileus?
If the risk is very low, because usually, yeah, the risk is very low. I mean, there was a controversy in the past in which you should do a cholecystectomy later, an interval cholecystectomy, if the patient is having a gallstone ileus, but I think this issue is almost resolved. The risk for recurrence is low. So just by doing the removal of the stone from the ileum, that should be fine, because the fistula itself is treating the problem in the gallbladder.
Okay. So Mohamed Al-Khalis is asking, why some surgeons don't perform intra-op cholangiogram during cholecystectomy, and when a T-tube is indicated and after cholecystectomy, it's only for uncomplicated acute cholecystitis.
Can you repeat the question, please?
He's asking why not all the surgeons perform intra-op cholangiogram, so why don't they perform it?
It's controversial. I mean, in the past, some surgeons used to advocate performing a routine cholangiogram, but really, if you are happy with the anatomy, you are obtaining your critical view of safety, you don't need to perform the intraoperative cholangiogram routinely.
Yeah.
Right. What's the second part of the question?
The second part is, why is the T-tube indicated only for indicated after cholecystectomy is done for uncomplicated acute cholecystitis?
I don't understand the question. I mean, I would do you would do a T-tube if there is still an obstruction in the common bile duct, but you rarely need to use a T-tube on days when you are performing cholecystectomy. With RCPs and that, it's rare that you need to perform you need to put a T-tube.
Okay. So someone's also asking, in COVID patients, how long can you keep them on antibiotics if they come in with gallbladder stones? And do you operate after resolving from COVID, or do you go ahead while they still have COVID?
I think you should avoid, if the patient is COVID positive, you should avoid performing a cholecystectomy in those patients. You should treat them conservatively. But if the patient is not COVID positive, you should, I think nowadays, if you are in a hospital whereby you can isolate those patients, your ICU in that hospital is managing the patients well without problems with shortage of ventilators or ICU beds. You should go ahead and perform surgery rather than waiting.
Okay. So we have a lot more questions. I'll try to read some of them. Dr. Badr Shaban is asking, when do you recommend an ERCP after biliary pancreatitis? And then if there's no ascending cholangitis and within a specific time frame or example for 48 hours or clinical improvement of a patient.
Dr. Badr, I wouldn't actually do an ERCP in gallstone pancreatitis unless there is a high suspicion of a presence of ductal obstruction from a stone. And usually, if the bilirubin is below 80, that's not the case. If the bilirubin is above 80, I would do an MRCP first prior to performing an ERCP in gallstone pancreatitis. But you can do it when the pain subsides. But you rarely need to perform an ERCP in gallstone pancreatitis because the stones that cause gallstone pancreatitis are usually small stones that will pass on their own.
There's an interesting question by Dr. Alia. She's asking, is Roa capsules effective for gallbladder stones, medications that dissolve cholesterol stones?
I think in some countries, like I had patients from Algeria saying that they are prescribing them bile salts when they are having gallstones, but I haven't come across studies showing the effectiveness of bile salts in treating symptomatic gallstone disease. We give bile salts after bariatric surgery for the first 6 months to prevent the formation of gallstones, and it is shown that it reduces the incidence of the requirement of cholecystectomy from 8% to 2% if you give bile salts for 6 months after bariatric surgery. But if the patient is having a symptomatic gallstones, you should do a cholecystectomy.
We have a lot more questions, but a little time. So we're going to take 2 more questions.
We can take as many as you like.
Okay. So let me see. There's someone called Faisal Khan saying, is there a physiological facilitation? Can there be a physiological facilitation in cases of acute obstruction?
I don't understand the question. If you mean Merisi Syndrome, yes. I mean, with recurrent inflammation, a large stone in the neck of the gallbladder can fistulize into the common bile duct. It can fistulize into the duodenum. It can fistulize even into the colon. It can fistulize into the liver, causing a liver abscess.
Okay, that's good. Dr. Mohammed, do you want to see the questions and see which ones you want to answer?
Where are the Q&A?
Yeah, Q&A.
Very nice questions. I like these, mashallah, very nice questions. Let me see. Can you comment on the camera lens, 30 degrees and port sizes you mentioned earlier? As a junior, I don't understand the reason. If you use 4 ports, you can have a good retraction of the gallbladder and you can perform the surgery safer. But there are meta-analyses showing that even if you use 3 ports, the cholecystectomy can be performed as safe as the 4 ports. I think the safest is with 4 ports. With 30 degrees lens, you can rotate the camera and you can look anteriorly and posteriorly nicely with 30 degrees or 40 degrees. But with the 0 camera, you cannot rotate and have a look. You cannot have a look at the critical review from the anterior side and the posterior side. Okay. Is Murphy sign always positive in cholecystitis? Whenever, nothing in medicine is always or never. Okay, so no, it's not always positive in cholecystitis. Okay. Is intraoperative cholangiography mandatory? It's not mandatory. Using lithotripsy to break down the stones, that's not done in gallstones, because the problem is the gallbladder itself. The gallbladder is forming the stones. So even if you break stones, the gallbladder will form more stones. Abhishek is asking, when will you suggest open cholecystectomy over laparoscopic? I would always, almost always, go for a lap cholecystectomy, unless the incidence, there is a very high suspicion of gallbladder cancer. If there is a high suspicion gallbladder cancer, then I will go and do an open cholecystectomy. But in other cases, I would go laparoscopic. All right. I think we answered most of the questions.
Yeah. There's one more question in the chat panel. It says, what's the difference in management if there's gallstones complicated by a gallbladder tumor?
Well, if there's a gallbladder tumor, you need to resect the gallbladder bed, or sometimes even perform right hepatectomy. But if you mean that the specimen, after you take the gallbladder out, you think it's a cholecystitis. You take the gallbladder out and the pathologist tells you that there is a cancer in that gallbladder. You need to know if it's invading the muscularis or not, because if it's invading further into the gallbladder, you need to go back and perform a resection of the gallbladder fossa, the liver itself, or even do a right hepatectomy.
All right, thank you, Doctor. This was an amazing lecture. So many questions, very informative. I hope we answered most of the questions. يعطيك ألف عافية, Doctor. We just have one, before everyone leaves, I need you guys to stay. We have one announcement. So I'm gonna just share the screen from my laptop. We have this code. We created codes, which are QR codes. So what you guys can do now is you guys can take a picture of these codes and it'll register you for the next session. So if you guys use Twitter, it'll take you to Twitter and Spotify and podcast. It'll take you immediately to our channel and then our Instagram page. And also it'll direct you to the page where you can register for the next session, which is Diseases in the Large Bowel by Dr. Ahmed Al-Khamis. So thank you guys for attending. We had a large group today at around 367 attended the full lecture. So you guys are amazing. We would like to thank you on behalf of all Surge Kuwait for your participants, and with you guys in it, we are actually ongoing. So I'll keep this page on for a few minutes so that you guys can take down all the registration details. And of course, we're going to send you broadcasts and we're going to announce them on all the social media pages. Thank you very much.